A suture pulls through skin with the faint whisper of surgical silk against tissue. Clean, precise, the kind of tension that holds without strangling. Dr. Sarah Vance works in Bay 4, third laceration of the night, her hands moving in small economical circles. The needle curves through dermis at exactly 15 degrees. Horizontal mattress stitch, old school. The kind medics use when supplies run short and wounds need to hold under stress. That's an unusual technique for a simple lac. She doesn't look up. Nurse practitioner Liu Chen stands at the edge of the curtain, arms crossed, watching with the intensity of someone who notices things others miss. It works, Sarah says. Military? Among other places. Liu's eyes narrow slightly, but she doesn't push. Not yet. The patient, a teenager who caught his arm on a fence, scrolls through his phone with his free hand. Doesn't even feel it. Sarah ties off the final knot and steps back. Keep it dry for 48 hours. If it reopens, come back. The kid nods and leaves. Sarah strips her gloves and tosses them in the red bin. The motion is smooth, automatic, like she's done it 10,000 times. Because she has. Before we begin, tell us where you are watching from, and if you want to support the channel, please subscribe and hit the like button on this video. The shift supervisor's voice cuts through the emergency department over the intercom. Dr. Vance, you're up for the next incoming. ETA 3 minutes. Sarah moves toward the board. A department hums with controlled chaos. Monitors beep in syncopated rhythm. A child cries somewhere in pediatrics. The smell of antiseptic mixes with floor cleaner and the faint metallic undertone of blood that never quite leaves a trauma center. Dr. Marcus Hyland stands near the central desk, reviewing charts on a tablet. 52. Silver at the temples. 25 years of emergency medicine carved into the lines around his eyes. Chief of the department. Brilliant diagnostician. And currently, the man least impressed with Sarah's presence. He glances up as she approaches. Vance. GSW to the thigh. Paramedics have it stabilized. Should be straightforward. His tone carries the weight of doubt. Think you can handle it without needing backup? Sarah meets his eyes, calm, unflinching. Yes. Good. Because I'd rather not have to scrub in on something that should be bread and butter for an attending. He turns back to his tablet. Dismissal without words. Liu watches the exchange from the nurse's station. She's seen this before. Hyland testing the new doctor. Pushing, waiting for a crack. Sarah doesn't crack. She walks to Trauma 2 and begins prepping. Gown. Gloves. The familiar weight of responsibility settling over her shoulders like an old coat. The doors burst open. 2 paramedics wheel in the gurney. The patient is a man in his 30s, conscious, pale, gripping the side rail with white knuckles. Pressure dressing on his left thigh, soaked through but holding. Vitals on the monitor, BP 90/60. Heart rate 110, breathing fast but controlled. Single GSW, lateral thigh, entrance only, no exit wound. Bleeding controlled in the field. Gave him 4 milligrams morphine en route, the lead paramedic reports. Sarah nods. Her eyes move over the patient in sections. Color, breathing pattern, the way he holds his leg, the angle of the dressing. The second paramedic is younger, maybe late 20s, lean, tattooed forearms. He lingers a half-second longer than necessary as the gurney locks into place, his eyes catching on something. Sarah reaches up to adjust her hair, tucking it behind her right ear. The paramedic freezes, just for a moment, a flicker of recognition. Behind her ear, barely visible unless you know to look, a small tattoo, an anchor with a caduceus, partially obscured by a thin surgical scar. Navy Hospital Corpsman Insignia. The kind you don't get unless you've earned it. His eyes snap to hers. She sees the question forming. Season start to open his mouth. Thank you. We've got it from here, she says, voice level, cutting him off before the words can form. He hesitates, then nods, backs out of the room. But his eyes don't leave her until the door swings shut. Liu steps beside Sarah, setting up the instrument tray. You know him? No. He looked at you like he did. Sarah pulls back the dressing. Blood wells up, dark and venous. She applies fresh gauze, pressure firm but measured. People see what they want to see. The patient groans. Sarah leans closer, her voice dropping into something softer, the kind of tone that cuts through pain. Hey, look at me. You're going to be fine. The bullet missed the artery. We're going to clean this up and get you stitched. You'll walk out of F here. He nods, breathing slowing. Lou watches her work. Watches the way Sarah's hands don't hesitate. The way she anticipates the next step before Lou even reaches for the instrument. Irrigation, debridement, probing for fragments. The bullet is lodged in the vastus lateralis, superficial enough to extract without vascular surgery. Sarah isolates it in 40 seconds, forceps. Lou hands them over. The bullet comes out clean. Sarah drops it into the metal tray with a dull clink. Dress it. He'll need a course of antibiotics and a follow-up in 5 days. She strips off her gloves and moves to the sink. Water runs over her hands. She scrubs in silence, watching the pink-tinged water spiral down the drain. Lou finishes with the patient and steps beside her. You've done this before. Sarah doesn't look up. It's a GSW, not exactly rare. No. I mean, you've done this before. The way you moved. The way you knew where the bullet was, before imaging. That's not something you learn in a residency. Sarah dries her hands, meets Lou's eyes in the reflection of the steel paper towel dispenser. Training, she says. Lou doesn't look convinced, but she doesn't push. Not yet. Sarah steps out of trauma 2. The department continues around her. Patients, nurses, residents running labs. The constant motion of a level 1 trauma center on a Friday night. Hyland stands near the desk, reviewing the case notes that just populated on the system. He glances at the timestamp. 12 minutes. GSW extraction, complete. His eyes lift, find Sarah across the room. She's already moving toward the next case. He frowns. If you want to see how Dr. Sarah Vance handles what comes next, make sure you subscribe to Emergency Heroes Stories. Because what she does in the next few minutes will leave you speechless. The intercom crackles. Incoming trauma. ETA 2 minutes. Sarah doesn't break stride. She's already at the board, reading the details. Already moving. The locker room smells like disinfectant and stale coffee. 2 residents lean against the metal lockers, voices low but carrying in the tile-walled space. Did you see Hyland's face when he checked her case time? The first one, a third-year named Patterson, pulls off his scrub cap. 12 minutes for a GSW extraction. That's faster than Chen could do it. She's prior military, right? The second resident, Okoye, younger, still has that nervous energy of someone 6 months out of med school. I heard she did field medicine or something. Field medicine isn't real medicine. Patterson tosses his cap into his locker. It's triage. Slap a bandage on and hope they make it to a real hospital. Hyland's right to keep her on simple cases until she proves she can handle actual emergency medicine. Okoye frowns. 12 minutes sounds like she can handle it. 1 case. Let's see if she keeps the pace. They leave. The door swings shut behind them. Sarah sits on the bench in the corner, out of sight, lacing her boots. She heard every word. She doesn't react, just pulls the laces tight and stands. The night moves in waves. Chest pain rolled out as gastritis. Pediatric fever, probable viral. Dislocated shoulder, reduced and splinted. Sarah works through the queue with mechanical efficiency, never lingering, never asking for help. Hyland watches from a distance, assigns her the cases no one else wants, the mundane ones, the teaching cases for interns. At 0230, a new patient rolls in. 54-year-old male, right upper quadrant pain, nausea, low-grade fever, probable cholecystitis, the triage nurse reports. Hyland glances at the board, then at Sarah. Vance, gallbladder consult. Get an ultrasound and surgical eval if needed. She nods. Bay 7. The patient lies on his side, knees drawn up. Face pale and slick with sweat. Classic Murphy sign. Tender on palpation. Guarding. Sarah runs through the initial exam. Pulse elevated. Temp 38.4. Respiratory rate normal. We're going to get some imaging and see what's going on, she tells him. Her voice is steady, reassuring without being dismissive. She orders the ultrasound and steps into the hall while the tech sets up. Lou passes by with a medication tray. Gallbladder? Looks like it. Hyland giving you all the exciting ones tonight. Sarah almost smiles. Almost. Keeps me busy. The ultrasound tech calls her back in. Sarah steps to the monitor, eyes moving over the grayscale images as they populate. Gallbladder. Thickened wall. Paracholecystic fluid. Textbook cholecystitis. But something else catches her eye. She leans closer. Go back to the previous view, upper pole. The tech scrolls back. There, a shadow. Subtle. Easily missed if you're only looking at the gallbladder. Sarah's. Oz's jaw tightens. Pan left. Show me the spleen. The tech adjusts the probe. The image shifts. The spleen comes into view. And beside it, a dark pooling. Free fluid in the perirenal space. Sarah's pulse doesn't spike. Her hands don't shake. But her mind is already moving. Splenic artery aneurysm. Ruptured. The patient isn't here for a gallbladder. He's bleeding internally. Call for an X-lap kit, now, and get Dr. Hyland in here. The tech hesitates. You want surgery for a gallbladder? He's not bleeding from his gallbladder. He's bleeding from a splenic artery rupture. If we don't get him to an OR in the next 10 minutes, he's going to code. The tech's eyes widen. She reaches for the phone. Sarah moves back to the patient. His pressure is dropping. 90/55 now. Heart rate climbing. 120. Sir, stay with me. We're going to take care of you. He nods weakly. Hyland pushes through the curtain 30 seconds later. Liu right behind him. What's going on? Sarah doesn't turn from the monitor. Splenic artery aneurysm. Ruptured. Free fluid in the abdomen. He needs surgery now. Hyland steps to the monitor. Studies the image. His expression shifts. How did you catch this? Saw the shadow on the initial view. This wasn't even the area of complaint. No, but it's what's going to kill him. Hyland's eyes move from the screen to Sarah. There's something in his gaze now. Not suspicion. Something sharper. Evaluation. Get him prepped. I'll call surgery. Lou moves fast, starting a second IV line, pushing fluids. Sarah stays at the patient's side, monitoring vitals, watching for signs of decompensation. The OR team arrives 6 minutes later. They wheel him out, fast but controlled. Hyland stands in the bay after they leave, arms crossed, staring at the now empty gurney. How did you know to look there? Sarah strips off her gloves. I didn't. I just saw something that didn't fit. That doesn't fit. Isn't a diagnosis. No, but it's a starting point. She moves toward the door. Hyland's voice stops her. Where did you train, really? She turns, meets his eyes. Everywhere that mattered, and she's gone. Liu watches her leave, then looks at Hyland. She just saved that man's life. Hyland doesn't respond, but his frown deepens. In the staff break room, Sarah pours herself a cup of coffee. It's burnt. Hospital coffee always is. She drinks it anyway. Her phone buzzes. A text from an unknown number. I know who you are. She stares at the screen, deletes the message, pockets the phone, drinks the coffee. At 04:15, radiology sends up the post-op imaging on the gallbladder patient. Confirmed splenic artery rupture. Surgical repair successful. The report includes a note from the attending surgeon. Good catch. Another 20 minutes and we would have lost him. Hyland reads it twice, then pulls up Sarah's file on his computer. Medical degree. Uniformed Services University of the Health Sciences. Residency. Naval Medical Center San Diego. Prior service. United States Navy. 12 years. Honorable discharge. No details beyond that. He sits back in his chair. 12 years. That's not just a tour. That's a career. He closes the file, but he doesn't stop thinking about it. In Bay 3, Sarah sutures a hand laceration. The patient is a line cook who slipped with a knife. 11 stitches. She works in silence. Each stitch placed with the same meticulous care as the last. Liu assists, handing her instruments before she asks. You've done a lot of these, Liu says quietly. Enough. More than most attendings I've worked with. Sarah ties off the final knot, cuts the suture. Experience comes from repetition. Or from being somewhere repetition wasn't optional. Sarah looks up. Liu holds her gaze. I'm not trying to pry, but whatever you did before this, it's showing. And people are starting to notice. Let them notice. Hyland doesn't like surprises. Then he shouldn't have hired me. Sarah strips her gloves and walks out. Liu stays behind, cleaning up the tray. She's seen a lot of doctors in 8 years. None of them move like Sarah Vance. None of them see things 60 seconds before anyone else does. And none of them carry themselves like someone who's already seen the worst and walked away. At 0500, the shift supervisor updates the board. Quiet night. Only 2 traumas, 16 total patients. Sarah is assigned to discharge paperwork. Hyland walks past her once. Doesn't say anything, but he watches. And Sarah knows it. She finishes her notes, logs out of the system, and heads toward the exit. In the ambulance bay, the young paramedic from earlier leans against his rig, arms crossed, waiting. Sarah stops. He straightens. Doc. She doesn't respond. You served with FMF, didn't you? Silence. I was Army, 68 Whiskey, Kandahar, 2018. He taps the side of his neck. I know the ink, and I know what it means. Sarah's expression doesn't change. Have a good night. She walks past him. He calls after her. Hey, just so you know, whatever you're hiding, it won't stay hidden long. Not if you keep working like that. She doesn't look back, but her hands, for just a moment, curl into fists, then relax. She keeps walking. The call comes in at 0642. Incoming trauma, GSW to the abdomen, male, 26, hypotensive, ETA 4 minutes. The department shifts. Residents move toward trauma 1. Nurses prep the bay. Hyland steps out of his office, already pulling on a gown. Sarah stands near the medication cart, restocking supplies from the last case. Hyland's voice cuts across the room. Vance, trauma 2, will take lead in 1. She doesn't hesitate, just nods and moves. Trauma 2 sits adjacent to trauma 1, separated by a retractable partition. She can hear everything happening on the other side. The organized chaos. Hyland's voice directing the team. Her bay is quiet. Lou enters, wheeling the crash cart. You got backup or just us? Just us, Sarah says. Lou raises an eyebrow, but doesn't comment. The doors explode open. 2 paramedics rush in, the gurney rattling over the threshold. The patient is young, conscious but fading, eyes wide and glassy, hands pressed to his abdomen, blood seeping between his fingers. The lead paramedic rattles off the report. Single GSW, left lower quadrant. Entry wound only. Pressure applied in the field. BP, 70/40. 2 large-bore IVs placed. Gave 1 liter en route. Minimal response. He's circling. They transfer him to the table. Sarah moves. No wasted motion. No hesitation. Lou, hang 2 units ONEG and push another liter of saline wide open. Get me a chest x-ray and a fast exam kit. Lou's already moving. Sarah cuts away the patient's shirt. The entry wound sits 2 inches left of the umbilicus. Small, deceptively clean. But the abdomen is distended, rigid, internal bleeding. She palpates gently. The patient groans, tries to pull away. Stay still. I know it hurts. Stay with me. His eyes find hers, terrified. Am I going to die? Her voice drops, steady, unshakable. No, not today. She pulls on gloves, preps the ultrasound probe. The fast exam takes 90 seconds. Free fluid in Morrison's pouch. Fluid in the pelvis. Dark, significant. Intra-abdominal hemorrhage. Lou, call the OR. Tell them we need an emergency X-lap. And get me a trauma panel. Type and cross for 6 units. On it. Sarah presses 2 fingers to the patient's radial pulse. Thready, weak. His pressure is dropping. 60/30 now. He's running out of time. She moves to his abdomen, applies a sterile dressing over the wound, then places both hands flat against his lower quadrants. Firm, even pressure. An old technique. Field expedient. Buying seconds. The monitor alarms. Heart rate 140. Oxygen saturation dropping. Rue, where's my blood? 30 seconds. The patient's eyes start to roll back. Hey, look at me. Sarah's voice sharpens, cuts through the haze. You stay here. You don't get to check out yet. His eyes flutter open. She keeps pressure on his abdomen, her other hand moving to his wrist. 2-finger pulse check. Steady, constant, the kind of touch that says, I'm not letting go. Lou hangs the blood. Sarah adjusts the flow to max. The OR calls back. They're ready. 5 minutes to transfer. Sarah shakes her head. He doesn't have 5 minutes. She looks at Lou. We're doing damage control here. Get me a central line kit, combat gauze, and a junctional tourniquet. Lou freezes. A junctional tourniquet? For an abdominal GSW? He's bleeding from a junctional vessel. If I don't control the hemorrhage now, he'll code before he makes it upstairs. That's not protocol. Protocol gets him killed. Their eyes lock. Lou moves. 30 seconds later, the supplies are on the tray. Sarah works fast. She places the central line in the femoral vein. Clean stick. First try. Secures it. Starts another unit of blood through the line. Then she irrigates the wound. The bleeding is worse than it looked. She packs it with combat gauze, layer after layer, applying direct pressure to the bleeding vessel. The junctional tourniquet goes around his pelvis, positioned over the iliac artery. She tightens it incrementally, controlled, precise. The bleeding slows, then stops. The monitor stabilizes. Heart rate drops to 110. Pressure climbs. 80/50. Lou exhales. How did you know that would work? Sarah doesn't. Is an answer? She's already calling the OR. Patient is stabilized, ready for transfer now. The OR team arrives 2 minutes later. They look at the setup, the central line, the packed wound, the junctional tourniquet. One of the surgeons, a colder woman with sharp eyes, pauses. Who placed this? I did, Sarah says. The surgeon studies her for a moment. You've done this before. Yes. Where? Sarah strips off her gloves. Somewhere it mattered. They wheel the patient out. The bay empties. Sarah stands alone, blood on her gown, hands steady at her sides. Through the partition, she hears Hyland's voice. His case is still going. Complex. Taking time. Lou returns with a towel. That was 14 minutes, start to stable. He's not stable. He's just stable enough. Still. 14 minutes. Lou hands her the towel. I've been doing this for 8 years. I've never seen anyone move like that. Sarah wipes her hands. Training. That's what you keep saying. Lou's voice softens. The training doesn't give you reflexes like that. Experience does. Sarah tosses the towel in the bin. Same thing. No, it's not. Lou steps closer. I watched you. You didn't think. You just moved. Like you've done it 100 times. That's not residency experience. That's combat experience. Sarah meets her eyes, says nothing. Lou nods slowly. Okay, you don't want to talk about it. Fine. But just so you know, whatever you're hiding, it's not a weakness. It's the reason that kid's alive. She leaves. Sarah stands in the empty bay, the smell of blood and antiseptic thick in the air. Her hands don't shake, but something inside her does. At 0730, the OR calls down. Patient in surgery. Hemorrhage controlled. Prognosis good. Hyland finishes his case 10 minutes later. He steps into the hallway, pulling off his gown, and sees the OR update on the board. He walks to Trauma 2. Sarah is cleaning up, restocking. Resetting the bay for the next case. Your GSW. She looks up. Stable. In surgery now. I saw the notes. You used a junctional tourniquet. Yes. That's not standard practice for abdominal hemorrhage. Standard practice would have gotten him killed. Hyland steps into the bay. Where did you learn that technique? Sarah sets down the gauze pack she's holding. Does it matter? It does if you're using non-standard interventions in my department. Your department just saved a life because of a non-standard intervention. His jaw tightens. I'm not questioning the outcome. I'm questioning the method. The method worked. This time. Every time. Silence. Hyland studies her. Really looks at her. The way she holds herself. The way her eyes don't waver. How many times have you done that procedure? Sarah pauses. Enough to know it works. That's not an answer. It's the only one you're getting. She walks past him. He doesn't stop her, but he watches her go. And for the first time, the suspicion in his eyes mixes with something else. Curiosity. In the locker room, Sarah sits on the bench, elbows on her knees, head down. Her hands are steady, but her breathing is shallow. She closes her eyes, sees the patient's face, the fear, the blood, sees other faces, other wounds, other rooms that smelled like copper and smoke. She opens her eyes, stands, walks to the sink, and splashes cold water on her face. When she looks up, Lou is standing in the doorway. You okay? Sarah dries her face. Fine. You don't look fine. I'm fine. Lou doesn't move. For what it's worth. You did good in there. Really good. Sarah nods. Thanks. Lou hesitates, then steps closer. I don't know what you saw before you came here. And I'm not going to ask. But whatever it was, it made you one hell of a doctor. Sarah looks at her. Or, it just made me fast. Same thing. Sarah almost smiles. Almost. She grabs her bag and heads for the door. Lou calls after her. Hey, next time Hyland tries to bury you in simple cases, remind him you just saved a life in 14 minutes. Sarah pauses. He won't need reminding. She leaves. Outside, the sun is rising. The city wakes. Traffic builds. The world moves forward. Sarah stands in the ambulance bay, staring at nothing. Her phone buzzes. Another text. Same unknown number. You can't hide forever. She stares at it, then puts the phone away, and walks to her car. The shift starts quiet. Sarah arrives at 1800, ties her hair back, checks the board. Standard Friday evening. Minor traumas, chest pain workups, a psychiatric hold waiting for placement. Hyland nods at her from across the department. No words, just acknowledgement. Progress, maybe. Lou passes by with a medication cart. Glad you're here. We're short-staffed tonight. Martinez called in sick and Chen's covering the ICU. I can handle it. I know you can. The first 3 hours pass in controlled rhythm. ankle fracture, migraine, pediatric fever. Sarah moves through cases with the same measured precision, never rushing, never hesitating. At 21:15, she's suturing a forehead lac in Bay 5 when the overhead speakers crackle. Attention all staff. Mass casualty incident. Multiple vehicle collision with structural collapse. Estimated 40 PS casualties. All available personnel to trauma receiving. This is not a drill. The department transforms instantly. Residents abandon paperwork. Nurses clear bays. The trauma attending steps out of his office, already barking orders. Set up triage in the ambulance bay. Red tags to trauma 1 and 2. Yellow tags to the main floor. Green tags to the waiting area. Move. Sarah finishes the last stitch. Ties it off, gives discharge instructions in 30 seconds, and moves toward the trauma corridor. Hyland stands at the center desk, coordinating bed assignments on the computer. Vance, you're taking overflow in trauma 3. Yellows and greens only. We need the main bays for critical. She nods. Trauma 3 is smaller, older equipment, used mostly for observation. She preps the space. Lou joins her, wheeling in extra supplies. You ever work in MCI before? Yes. How bad? Sarah doesn't answer, just keeps stocking shelves. The first ambulance arrives at 21:30, then another, then 5 more. The bay floods with noise, sirens, radio chatter, voices overlapping. The controlled chaos of a system pushed to its limit. Sarah treats a woman with a fractured wrist, a man with lacerations across his chest, a teenager with a dislocated shoulder. She works fast, efficient, moves to the next patient before the last one is even transferred out. At 22:10, the ambulance bay doors open again. A gurney rolls in, flanked by 2 paramedics moving with urgent precision. The lead paramedic is familiar, Jake Mendoza, 29, the one who recognized her tattoo. He's covered in dust and blood, not all of it his patient's. Critical patient, construction worker, crush injury to the lower extremities. Field tourniquet placed at 1900, approximately 3 hours ago. Vitals are holding, but he's starting to show signs of compartment syndrome. Hyland looks up from the desk. Trauma 1 is full, 2 is full. Take him to 3. Jake's eyes find Sarah across the ring. He doesn't look away. Doc, I think you need to see this one. Sarah steps forward. The patient is a man in his 40s. Conscious, alert, pale. His left leg is wrapped in a tourniquet, applied high on the thigh. The distal limb is swollen, mottled, the skin tight and shiny. Wrong placement, wrong tension. Too long. Sarah's jaw tightens. She moves to the gurney, hands already assessing. Pulses absent below the knee. Capillary refill time delayed. The classic signs of vascular compromise and rhabdomyolysis starting to set in. Get him into 3, now. They wheel him in. Lou is already setting up monitors. Sarah pulls on gloves, her mind running through the timeline. 3 hours with improper tourniquet placement, muscle breakdown, potassium release. Risk of cardiac arrest from hyperkalemia, compartment syndrome developing, tissue ischemia accelerating. The clock is ticking. 90 minutes before irreversible damage. Maybe less. Jake stands at the edge of the bay, watching. The guy who placed the tourniquet was a first responder. He did his best. His best is killing him, Sarah says, not looking up. She starts an IV, draws labs, pushes fluids. The monitor beeps. Heart rate 100. Blood pressure stable for now. But the potassium level comes back elevated. 5.8. Climbing. Lou, push calcium gluconate and sodium bicarb. Start preparing for possible dialysis. Lou moves fast. Sarah examines the leg again. The swelling is worse. The compartment pressure building. She can feel it under her hands. Standard protocol, fasciotomy. Relieve the pressure, hope the muscle is salvageable. But something nags at her. The swelling pattern, the way the venous congestion extends proximally. Not just distally. This isn't just compartment syndrome. This is central vascular obstruction. The tourniquet compressed the femoral vein for 3 hours. Blood backed up, clot formation. Now the venous return is blocked. A fasciotomy won't fix that. She needs to restore flow, fast. Her mind cycles through options. REBOA, resuscitative endovascular balloon occlusion of the aorta. It's designed for hemorrhagic shock. For buying time in trauma when a patient is bleeding out and you need to get them to an OR. But it can also be used to isolate vascular flow, to control pressure, to give you a window. It's not standard for this indication. It's risky. And if she does it, everyone will know. Jake steps closer. Doc. She looks up. His eyes are steady, knowing. I know who you are. Silence. I was in Kandahar. 2018. I saw the Navy medics work. I saw what they could do when everything else failed. He taps the side of his neck, where his own unit tattoo sits. I know that ink. And I know what it means. Sarah's hand still. This isn't the field. No, but he's dying just the same. The monitor alarms. Heart rate spiking. 120. EKG showing peaked T waves. Hyperkalemia. Worsening. The patient's eyes flutter. I can't feel my leg, he whispers. Sarah looks at him, then at the monitor, then at Jake. If she does nothing, he loses the leg. Maybe his life. If she does this, everything changes. Lou steps beside her. Sarah, what do you need? Sarah's jaw sets. Get me a 7 French sheath, guide wire, and someone find me a Reboa catheter. Lou's eyes widen. A Reboa catheter? For compartment syndrome? He doesn't just have compartment syndrome. He has central venous obstruction. If I don't restore flow now, he codes in the next 10 minutes. That's not protocol. Protocol gets him killed. The same words. The same stakes. Lou doesn't hesitate this time. She moves. Jake stays. You sure about this? Sarah pulls on a sterile gown. No. But you're doing it anyway. Yes. He nods. Then I'll make sure no one interrupts. He steps to the doorway, arms crossed, a silent sentinel. Sarah precs the femoral access site. Her hands move with absolute certainty now. No hesitation. No doubt. This is what she was trained for. This is what she's done 40 times before. Just never here. Lou returns with the supplies, sets them on the tray. OR is asking what we're doing. Tell them we're buying time. Sarah makes the incision. Femoral cut down. Isolates the artery. Threads the guide wire under direct visualization. The sheath goes unclean. She advances the Reboa catheter. Watches the length. Feels the resistance. Zone 1. Just below the diaphragm. She inflates the balloon. The monitor changes. Pressure redistributes. Blood flow redirected. The distal leg perfusion drops temporarily, but the proximal venous congestion begins to decompress. Sarah works fast now. Decompresses the compartments with targeted fasciotomies. Evacuates the clot. Restores flow. The monitor stabilizes. Heart rate drops to 90. Potassium trending down. Distal pulses return, faint but present. Lou exhales. It worked. Sarah deflates the balloon slowly, removes the catheter, closes the access site. Get him to the OR. He needs vascular surgery and orthopedic consult. But he'll keep the leg. The OR team arrives. One of the surgeons looks at the setup. The femoral line. The Reboa kit. Who placed this? Sarah strips off her gloves. I did. The surgeon's eyes narrow. You're an EM attending, not vascular. I know. Where did you learn this? Sarah meets her gaze. Does it matter? The surgeon pauses, then nods. Good work. They wheel the patient out. The bay empties. Sarah stands alone, blood on her gown, the weight of the moment settling over her. Behind her, Hyland's voice. What the hell just happened? She turns. He stands in the doorway, arms crossed, eyes hard. I stabilized a patient. You performed a Reboa procedure in an ER bay. That's not standard care. Standard care would have cost him his leg. That's not the point. Then what is? Hyland steps closer. The point is you're using advanced trauma techniques that most surgeons don't even know. And you're doing it like you've done it 1,000 times. Sarah doesn't flinch. 40 times, not 1,000. Silence. Hyland stares at her. What? You asked where I learned it. I learned it in the field, and I've done it 40 times. Her voice is steady, unshaken. I was a Navy hospital corpsman, Fleet Marine Force. 4 deployments, Helmand Province. I taught prolonged field care to MARSOC and SEAL medics at Camp Pendleton. The room goes silent. Even the monitors seem quieter. Hyland's expression shifts. Suspicion, shock, something else. Why didn't you tell us? Sarah's eyes don't waver. Because the last time I made a call like this, a 22-year-old Marine died while I saved 3 children. I was right. I was cleared. And I still see his face every time I close my eyes. Hyland doesn't respond. Can't. Sarah walks past him, out of the bay, into the corridor. Behind her, Lou and Jake exchange glances. Jake nods once. Respect. Unspoken. Absolute. The MCI winds down over the next 2 hours. Hours. The last ambulances depart. The The trauma bay's empty. Patients are distributed throughout the hospital, some to surgery, some to ICU, some to floors. The walking wounded discharged with instructions and follow-up appointments. By midnight, the department returns to something resembling normal. Sarah stands at the sink in the staff restroom, scrubbing blood from under her fingernails. The water runs pink, then clear. She dries her hands and stares at her reflection. Exhausted eyes, hair pulled back tight. The small tattoo behind her right ear visible, now that the adrenaline has faded, and she's stopped caring who sees it. The door opens. Liu steps in. Highland wants to see you. Sarah doesn't turn. Now? Now. She follows Liu down the corridor to Highland's office. The door is half open. He sits behind his desk, reading something on his computer screen. Liu knocks. Dr. Vance. Highland looks up, gestures to the chair across from him. Come in. Close the door. Sarah enters. The door clicks shut behind her. She doesn't sit. Highland studies her for a long moment. Then he turns the monitor toward her. On the screen, her personnel file. Military service record, dates of deployment, unit assignments, awards, Navy and Marine Corps Commendation Medal with Valor, Combat Action Ribbon, 4 deployment stars. He scrolls down. Silver Star, for actions during a mass casualty event in Helmand Province. 22 friendly casualties, 43 local nationals, 16 hours of continuous care under fire. Highland leans back in his chair. You didn't mention the Silver Star. You didn't ask. I asked where you trained. And I told you, everywhere that mattered. His jaw tightens. You know what I mean. Sarah crosses her arms. You wanted to know if I could handle emergency medicine. I've been handling it. Tonight proved that. Tonight proved you're operating at a level most trauma surgeons can't match. That's not normal for a first-year attending. I'm not a normal first-year attending. No, you're not. He closes the file. You're a decorated combat medic with more field experience than half my staff combined. And you've been letting us treat you like you don't know what you're doing. I never said I didn't know what I was doing. You assumed. Silence. Highland's expression shifts. Not anger. Something closer to regret. You're right. I did assume. He exhales. I had a bad experience with a military medic 10 years ago. Disaster scene. Multi-vehicle pileup. He made a call that cost a patient. I've been carrying that ever since. Sarah's voice softens. Just slightly. One medic, one mistake that doesn't define all of us. I know that now. He stands, walks to the window overlooking the ambulance bay. I looked you up after the gallbladder case. Saw the basics. Navy. Honorable discharge. But nothing detailed. No specifics. He turns to face her. Why did you leave? Sarah's jaw sets. That's not relevant. It is if it affects your ability to practice here. It doesn't. Then why hide it? Her hands curl into fists at her sides, then relax. Because people hear combat medic, and they think I'm either broken or dangerous. They think PTSD. They think liability. They don't think competence. Her voice stays level, controlled. I didn't hide what I can do. I just didn't advertise it. There's a difference. Highland nods slowly. Fair enough. He pauses. For what it's worth, what you did tonight saved a man's life, and I was wrong to doubt you. Sarah meets his eyes. I don't need you to not doubt me. I just need you to let me work. You've been working, and you've been exceptional. He returns to his desk, which is why I want to offer you something. Before he can continue, his pager goes off. He glances at it, frowns. Trauma alert. Incoming critical. Sarah's already moving toward the door. Wait. Highland's voice stops her. This one's different. Severe polytrauma. They're calling it a likely expectant. Expectant. The term used in triage for patients too far gone to save. The ones you make comfortable while you focus resources on the salvageable. Sarah's expression doesn't change. Where? Trauma 1. ETA 3 minutes. They move together down the corridor. Liu falls in step beside them, already pulling on a gown. The trauma bay fills with staff, residents, nurses, respiratory therapy standing by. The doors burst open. Jake Mendoza and another paramedic wheel in the gurney at a near run. The patient is a woman, mid-30s, unresponsive, intubated in the field, covered in blood and debris. The smell of gasoline and burnt rubber clings to her. Jake's voice is tight, controlled, but there's something underneath it. Motor vehicle collision, ejected from vehicle. Found unresponsive, GCS 3, multiple fractures, open head injury, bilateral chest trauma. She's been down twice. We got her back both times, but she's not holding. The monitor shows the story in numbers. Heart rate 160, blood pressure 60 over palp. Oxygen saturation 78%, despite being bagged. She's dying. Highland steps to the head of the bed, assessing. Pupils fixed and dilated. No response to pain. Massive head trauma. He looks at the monitor. She's been down too long. Even if we get her back, there's likely no meaningful recovery. One of the residents speaks up. Do we call it? Highland hesitates. Sarah steps forward. She looks at the patient. Really looks. The chest rise is asymmetric. Left side not moving. Tension pneumothorax. The trachea is deviated. Jugular veins distended. Air trapped in the chest cavity, collapsing the lung, compressing the heart. Fixable. She moves to the left side of the bed, places her hands on the chest wall, feels the crepitus under her fingers, subcutaneous emphysema. She's not gone. She's got a tension pneumo. That's why she's not oxygenating. Highland looks at her. Even if we decompress the head injury, we don't know the extent until we stabilize her. Right now she's hypoxic and hypotensive. Fix that first. Sarah, she's been down for over 12 minutes total. The likelihood of neurological recovery is 0 if we don't try. Their eyes lock. The room goes quiet. Highland's voice drops. This is a judgment call, and I'm making it. We're calling time of death. Sarah doesn't move. No. Excuse me? I said no. Her voice is calm, absolute. I've been in rooms where everyone said the patient was gone, and I've walked out of those rooms with a pulse. I'm not calling this. You don't have the authority. Then give it to me. Silence. Jake watches from the corner. Lou stands frozen, hands on the crash cart. Highland stares at Sarah. She doesn't blink. If I do this and she doesn't make it, that's on me, Sarah says. But if we don't try and there was a chance, that's on all of us. Highland's jaw works. Then he steps back. You've got 5 minutes. Sarah moves. Lou, needle decompression kit. 14 gauge, now. Lou's hands fly. Sarah palpates the second intercostal space, mid-clavicular line, preps the site. Inserts the needle. There's a hiss of air. Immediate, loud. The patient's chest rises on the left side. The monitor changes. Oxygen saturation climbs. 80, 85, 90. Heart rate starts to drop. 140, 120. Blood pressure rises. 70 over 40, 80 over 50. Sarah places a chest tube, secures it. Blood and air drain into the collection chamber. Get me a CT, head, chest, abdomen, and call neurosurgery. Highland stares at the monitor. The patient is stabilizing, still critical, still traumatized, but alive. One of the residents exhales audibly. She's got a pulse. Sarah steps back, strips off her gloves. She always had a pulse. It was just buried under a fixable problem. Highland looks at her. Something in his expression shifts. Respect, reluctant, but real. That was a hell of a call. Sarah's voice is quiet. It wasn't a call. It was a refusal. A refusal? To give up when there's still a chance. She walks out of the trauma bay, into the hallway, leans against the wall. Her hands are steady, but inside, she's shaking. Jake follows her out. Doc, she looks at him. You just brought someone back from the dead. She wasn't dead. She was just close. Most people wouldn't have seen the difference. Sarah's eyes meet his. I've seen the difference. I know what dead looks like. That wasn't it. Jake nods. For what it's worth, I'm glad you didn't listen to him. So am I. He starts to leave, then pauses. That Marine, the one you mentioned, the 22-year-old. Sarah tenses. What about him? Was it Helmand? 2015? Her eyes narrow. How do you know that? Because I heard the story. It went through the whole infantry pipeline. Navy medic, outnumbered, compound under siege. She had to choose between a Marine with a femoral bleed and 3 local kins trapped under rubble. She chose the kids. The Marine didn't make it. He pauses. They said she made the right call, that the Marine was too far gone, that she saved the lives she could. Sarah's voice is barely a whisper. They said a lot of things. They also said she got a silver star, and that she refused to wear it. Silence. Jake's voice softens. You made the right call then, and you made the right call tonight. Don't let anyone tell you different. He walks away. Sarah stands alone in the empty hallway. The fluorescent lights hum overhead. Somewhere in the distance, a monitor beeps. She closes her eyes, sees the Marine's face, sees the children, sees tonight's patient, alive because she refused to quit. She opens her eyes and walks back into the department. The patient from the bridge collapse codes at 0200. Sarah is in the break room, forcing down coffee that tastes like burnt rubber when the overhead speaker crackles. Dr. Vance to Trauma 1. Dr. Vance to Trauma 1. Code Blue. She's moving before the announcement finishes. The bay is chaos when she arrives. The construction worker. The one with the crush injury. The one she stabilized with the Raboa. He's seizing. Violent. The bed rails rattling. 2 nurses struggle to keep him from falling. The monitor screams. Heart rate 200. Rhythm erratic. Ventricular tachycardia spiraling toward fibrillation. The vascular surgeon stands at the bedside, hands raised, uncertain. He was stable 20 minutes ago. Post-op vitals were good. Then he just crashed. Sarah moves to the monitor, reads the rhythm, sees the peak T waves again. Hyperkalemia. Worse than before. Did anyone check his potassium post-op? The surgeon's face goes pale. It was supposed to be in the standing orders. Was it checked or not? I don't know. Sarah turns to Lou. Get me his latest labs, now. Lou pulls it up on the computer. Her face drains of color. Potassium 7.2. Drawn 30 minutes ago. Critical. Life-threatening. Sarah's mind races. The muscle breakdown from the prolonged tourniquet. The compartment syndrome. The surgery released more damaged tissue. More potassium flooding his system. They treated the mechanical problem, but not the metabolic cascade. And now his heart is paying the price. Push calcium chloride. 10 milliliters IV push. Then insulin and dextrose. Get dialysis up here now. She moves to the bedside. The patient's eyes are rolled back. Foam at the corners of his mouth. His whole body rigid. We need to cardiovert. Highland appears in the doorway, pulled from another case. What's happening? Hyperkalemia from rhabdomyolysis. The surgery released more necrotic muscle. His potassium spiked. He's in VTAC. Highland looks at the monitor. Cardioversion might not hold if we don't stabilize the electrolytes first. We don't have time. He's going to arrest. As if on cue, the monitor flatlines. VFib. Sarah grabs the defibrillator paddles. Charge to 200. Everyone clear. She shocks him. His body arcs off the bed. The rhythm doesn't change. Charge to 300. Shock. Still VFib. Start compressions. Push epi, 1 milligram. Lou climbs onto the bed. Begins chest compressions. Hard, fast, the way you do when you mean it. Sarah watches the monitor. Counts. 30 seconds. A minute. 2 minutes. The rhythm flickers but doesn't convert. Highland steps closer. Sarah, we've been at this for 4 minutes. With his potassium that high, I'm not calling it. He's not coming back. He came back twice in the field. He'll come back now. That's not how this works. She looks at him. I know exactly how this works. I've done this in places where there was no backup. No ICU waiting upstairs. No dialysis machine. Just me and whatever I could carry. And I didn't quit then. I'm not quitting now. Her voice doesn't rise, doesn't break. It's steel wrapped in calm. Highland steps back. Sarah turns to the crash cart. Lou, stop compressions. I'm going to try something. Lou climbs down, breathing hard. Sarah pulls a long needle from the cart. A cardiac syringe. Highland's eyes widen. What are you doing? Intracardiac calcium, direct to the myocardium. That's not standard. Nothing about tonight has been standard. She positions herself at the 4th intercostal space, palpates the landmarks, inserts the needle at a steep angle, aiming for the heart. She aspirates. Blood fills the syringe. She's in. Injects the calcium directly into the cardiac muscle. Pulls the needle out. Resume compressions. Lou climbs back up. Pushes. The room is silent except for the sound of ribs flexing under Lou's hands and the steady alarm of the monitor. 10 seconds. 20. 30. The monitor flickers. A single blip. Then another. Then a rhythm. Sinus tachycardia. Fast, but organized. The patient gasps. A ragged, desperate pull of air. Lou stops compressions. Everyone stares at the monitor. The rhythm holds. Heart rate 140. Dropping slowly. 130. 120. Blood pressure returns. 70/40. Rising. Sarah exhales. Get dialysis up here, now, and keep pushing calcium and bicarb until his potassium is under 6. The vascular surgeon just stares. How did you know that would work? Sarah strips off her gloves. I didn't, but I knew doing nothing wouldn't. She starts to walk out. Highland's voice stops her. Sarah. She turns. He's looking at her differently now. Not with suspicion, not with doubt, with something closer to awe. Where did you learn to do that? She pauses. The room is watching. Liu, the nurses, the residents, Jake, who appeared sometime during the code and now stands silently by the door. She could deflect, could give another vague answer, but she's done hiding. Camp Bastion, Helmand Province, 2013. We had a Marine go into hyperkalemic arrest after an IED blast. No dialysis, no ICU, just a field hospital with limited supplies. Her voice is steady, matter of fact. I was the senior corpsman on duty. I did what I had to do. He lived. Silence. I was the lead instructor for the Navy's prolonged field care course at Camp Pendleton. I trained special operations medics, SEALs, Marine Raiders, Force Recon. I taught them how to keep people alive when everything says they should be dead. She looks around the room. I've done this 43 times, not in clean hospitals with backup, in dirt, in blood, under fire, and I didn't lose a single one. No one speaks. I left the Navy 3 years ago, went to medical school, did my residency, came here to practice civilian emergency medicine because I thought I could leave the war behind. Her jaw tightens, but you can't leave it behind. It's in your hands, in your instincts, in the way you see a patient and know what's wrong before the tests come back. She looks at Highland. You asked why I didn't tell you. Because every time I do, people either treat me like I'm broken or like I'm a liability. They don't see competence, they see baggage. Highland's voice is quiet. I don't see baggage. I see someone who just saved 2 lives tonight that everyone else had written off. Sarah doesn't respond, just turns and walks out. Into the hallway, into the empty locker room. She sits on the bench, elbows on her knees, head in her hands. The door opens. Jake steps in. You okay? No. He sits beside her. That was the gutsiest thing I've ever seen. It was desperation. No, it was skill, and experience, and refusal to accept defeat. He pauses. You know what we called medics like you downrange? She looks at him. We called you wizards, because you did things that shouldn't work. And they worked anyway. Sarah's throat tightens. I'm not a wizard. I'm just stubborn. Same thing. A long silence. That Marine, Jake says quietly. The one from Helmand. I looked it up after we talked. His name was Lance Corporal David Chen, 22. Femoral artery severed by shrapnel. You were alone with him and 3 children trapped under a collapsed wall. You had 1 tourniquet, 1 IV kit, 1 pack of Quick Clot. Sarah closes her eyes. Don't. You put the tourniquet on him, started the IV, then the building started coming down. You had maybe 2 minutes. You could stabilize him and let the kids die. Or you could pull the kids out and know he wouldn't make it. Stop. You pulled the kids out, all 3, then went back for him, but he'd already bled out. Her hands are shaking now. The court-martial cleared you, said you made the right tactical decision. That Chen's injury was non-survivable, even with immediate surgical intervention. That you saved 3 lives instead of losing 4. They weren't there. No, but you were, and you've been carrying him ever since. Sarah's voice breaks. He looked at me. Right before I left him, he knew. He knew I was choosing them over him, and he nodded, like he understood, like he was giving me permission. Tears run down her face. I see that nod every time I close my eyes. Jake's hand rests on her shoulder. He nodded because he was a Marine, and Marines don't leave kids behind. He was telling you to do your job, and you did. It doesn't feel like I did. It never does, but that doesn't make it wrong. She wipes her eyes. I came here to get away from that, from having to choose, from triage, from war. You can't get away from war, Doc. You can only decide what to do with what it taught you. She looks at him. And what did it teach me? That you don't quit, ever, no matter what the monitor says, no matter what anyone else thinks. He stands. Tonight, you proved that, twice. He walks to the door, pauses. For what it's worth, Chen would be proud. He leaves. Sarah sits alone, the weight of 3 years pressing down on her shoulders. But somehow, it feels lighter now. She stands, washes her face, looks at herself in the mirror. The tattoo behind her ear catches the light. She doesn't hide it this time, just pulls her hair back and walks back into the department. The construction. Construction worker is stable now. Dialysis running. Potassium dropping. He'll live. Highland stands at the central desk. When he sees Sarah, he gestures to his office. She follows. He closes the door. Sit. She does. He sits across from her. I owe you an apology, a real one. You already. No, I apologized for doubting your competence. But I need to apologize for making you feel like you had to hide who you are. He leans forward. What you did tonight, Oak saves, that's not just good medicine, that's exceptional medicine. The kind most doctors will never achieve. I was just doing my job. Your job was to stabilize and transfer. You went beyond that, way beyond. He pauses. I want to offer you something. A position. Trauma Fellowship Director. You'd be in charge of training the next generation of emergency physicians, specifically, developing a program for military to civilian medical transition. Sarah stares at him. You want me to teach? I want you to build something. A bridge between what you learned out there and what we do in here. Because clearly there's a gap, and you're uniquely qualified to fill it. She's silent for a long moment. I'll do it, on one condition. Name it. I teach what works, not what's comfortable, not what's always protocol, what actually saves lives. Highland smiles. I wouldn't expect anything less. 6 months later, the conference room on the 3rd floor has been converted into a teaching space. Whiteboards line the walls, covered in anatomical diagrams and procedural notes. A crash cart sits in the corner. A simulation mannequin lies on a gurney in the center. Sarah stands at the front, wearing scrubs and a white coat. Her hair is pulled back, the tattoo behind her ear visible. She doesn't hide it anymore. 12 residents sit in a semicircle, faces attentive, notebooks open. Prolonged field care isn't about doing more, Sarah says. It's about doing what matters with what you have. In a hospital, you have everything. Labs, imaging, specialists down the hall. But in a disaster, in a mass casualty, in the field, you have your hands and your brain. That's it. She moves to the mannequin. Today we're covering damage control resuscitation. The goal isn't perfect. The goal is survivable. You buy time. You stabilize. You move to the next patient. One of the residents raises a hand. Young, eager, first year. Dr. Vance, isn't that just triage? Triage decides who gets care. Damage control decides how much care and how fast. They're related, but not the same. She demonstrates a tourniquet placement. High, tight, proximity to the injury. You have 2 minutes to control hemorrhage, or you lose the patient. What do you do? The residents call out answers. Pressure, hemostatic agents, tourniquets. Good. No, the bleeding is controlled, but the patient is in shock. No IV access. Veins are collapsed. What do you do? Silence. Sarah picks up a needle. Intraosseous line. Directly into the bone marrow. Fastest access in a crashing patient. She demonstrates on the mannequin. The residents lean forward, watching. Lou enters quietly, carrying a tablet. She waits until Sarah finishes the demonstration before approaching. Sorry to interrupt. You have a visitor. Sarah frowns. I'm in the middle of a session. I know, but he says it's important. He's from the Navy. Sarah's expression shifts, just slightly. She turns to the residents. Take 15 minutes. Review the intraosseous access protocol. We'll reconvene and you'll each demonstrate on the mannequin. She follows Lou into the hallway. A man in a Navy service uniform stands near the elevators. Commander rank insignia, Medical Corps, 50, graying at the temples. The kind of bearing that comes from decades of service. He extends a hand. Dr. Vance, Commander Peter Stahl, Navy Bureau of Medicine and Surgery. Sarah shakes his hand. Commander, what brings you here? You do. He gestures to a quieter corner of the hallway. May we speak privately? They move away from the elevators. Stahl pulls out a tablet, brings up a file. We've been following your work here. The Reboa procedure during the bridge collapse. The intracardiac calcium administration. The gallbladder case that turned into a splenic rupture. He looks up. You've had a remarkable 6 months. I've been doing my job. You've been doing more than that. You've been innovating. Adapting field protocols to civilian emergency medicine. That's exactly what we need. Sarah's eyes narrow. What do you need, Commander? We're updating the prolonged field care curriculum. The program you helped develop at Pendleton is being expanded. We want to integrate more civilian trauma techniques. Bridge the gap between what works in a hospital and what works at a forward operating base. He pauses. We want you to consult on the update, review protocols, train the trainers. Sarah is silent. It would be a contract position, civilian. You wouldn't be rejoining active duty. 4 trips a year to Pendleton, 2 weeks each. You'd be compensated at the GS-14 level. Why me? Because you've lived both sides. You've saved lives in Helmand and you've saved lives here. You know what works in both environments. That perspective is rare. Sarah looks away, down the hallway, toward the conference room where her residents wait. I left the Navy because I needed distance from the war. I understand, but this isn't about going back to war. It's about making sure the next generation of medics has the skills to bring people home alive. She meets his eyes. I need to think about it. Of course, take your time. He hands her a card. My contact information, no pressure. But I hope you'll consider it. He leaves. Sarah stands in the empty hallway, turning the card over in her hands. Lou approaches. Everything okay? Yeah, just unexpected. Good unexpected or bad unexpected? Sarah doesn't answer, just pockets the card and returns to the conference room. The residents look up expectantly. All right, pair up. One of you is the patient, one is the medic. You have a femoral bleed and no surgical backup. Show me what you do. They move quickly, organizing into pairs. Sarah circulates, watching, correcting hand positions, offering guidance. One resident struggles with the IO needle placement. Sarah steps in. You're going too shallow. You need to feel the pop when you break through the cortex, like this. She demonstrates. The needle sinks into the mannequin's tibia with a distinct give. There, now you try. And the resident does it correctly the second time, smiles. I felt it. Good. Now you'll never forget. At the end of the session, the residents file out. One lingers. Patterson, the third year who doubted her 6 months ago. Dr. Vance, can I ask you something? Go ahead. When you were deployed, did you ever have a case where you knew the protocol wouldn't work, but you followed it anyway? Sarah considers the question. No, if I knew it wouldn't work, I didn't follow it. But what about regulations? Chain of command. Chain of command matters, but when someone is dying in front of you, your chain of command is your training and your conscience. If you know a better way, you use it. Then, you document the hell out of it and explain why. Patterson nods slowly. That makes sense. I just worry about stepping outside the lines. The lines are there to guide you, not trap you. Learn them, respect them, but don't let them kill your patient because you're afraid to adapt. Yes, ma'am. He leaves. Sarah cleans up the teaching space, restocking supplies, resetting the mannequin. Her phone buzzes. A text from the construction worker she saved. His name is Miguel Torres. He's been texting her periodic updates. Walking a mile today. No cane. Thank you for not giving up on me. She smiles. Types back. You did the hard part. Keep going. Another text comes in. This one from Jake. Drink tonight? Lou and I are grabbing dinner after shift. You should come. She hesitates, then types. Sure. Where? Hannigan's, 7 o'clock. She pockets the phone. At 1900, she walks into Hannigan's. It's a dive bar 3 blocks from a hospital. Dim lighting, wood paneling, the smell of fried food and beer. Jake and Lou sit in a corner booth. They wave her over. Look who decided to join the living, Lou says. Sarah slides into the booth. I've been busy. Too busy. You need to decompress. Lou pushes a menu toward her. Eat something that isn't hospital cafeteria food. They order. Burgers, fries, beer for Jake and Lou, water for Sarah. How's the teaching going? Jake asks. Good. The residents are eager. Some of them are really sharp. Any of them give you trouble? Not anymore. Lou grins. I heard Patterson is practically worshipping you now. Complete 180 from 6 months ago. He just needed to see it work. You mean he needed to see you save 3 impossible cases in one night and realize he was wrong? Sarah shrugs. Same thing. The food arrives. They eat in comfortable silence for a few minutes. Then Lou speaks. So, Navy guy showed up today. What was that about? Sarah sets down her burger. They want me to consult on updating field protocols. Training instructors at Pendleton. Jake's eyebrows rise. That's a big deal. It's also complicated. Because you'd be going back? Not back to active duty, but back to that world, that environment. Lou leans forward. Do you want to do it? Sarah is. It's quiet for a long moment. Part of me does. The part that knows I could help, that knows the training could save lives. And the other part? The other part remembers why I left, remembers the weight of it, the decisions, the faces. Jake's voice is gentle. You know you don't have to carry that alone, right? That's what therapy is for. That's what we're here for. I know. Do you? Because you still act like you have to be bulletproof. Sarah looks at him. Old habits. Yeah. Well, Maybe it's time for new ones. She nods slowly. Maybe. They finish the meal, talk about lighter things, hospital gossip, bad patients, worse doctors. At 2100, Sarah's phone rings. Highland. She steps outside to take it. Dr. Vance, sorry to call after hours, but we just got word. There's a situation developing. Multi-agency disaster drill tomorrow. They want our team to participate. Specifically, they requested you. What kind of drill? Simulated building collapse. Mass casualty. Interagency coordination between fire, EMS, and hospital response. Why me? Because word got out about what you did during the bridge collapse. They want someone with field experience to advise on triage and damage control in an austere environment. Sarah closes her eyes. Everywhere she turns, the past reaches for her. What time? 0600. Briefing at the Fire Academy. I'll be there. Thank you. And Sarah, this is good exposure for the program. For what you're building here. Understood. She hangs up, stands on the sidewalk, looking up at the city lights. Jake steps out. Everything okay? Yeah, just work. You sure? She turns to him. Do you ever feel like you can't escape what you were? Every day. How do you deal with it? I stopped trying to escape it. Started trying to use it. He pauses. You're not the same person you were in Helmand. But that person is still part of you, and that's not a bad thing. It doesn't feel like a good thing. That's because you're still fighting it. Stop fighting. Start integrating. She considers this. The Navy wants me to train medics. Highland wants me to build a program. Everyone wants me to go back to what I was. No, they want you to be what you are, which is someone who knows how to save lives when it's hard. That's not going back. That's moving forward with everything you've learned. Sarah exhales. I'll think about it. Good. Now get out of here. Go home. Sleep. Tomorrow you've got a disaster drill and a decision to make. She almost smiles. Thanks, Jake. Anytime, Doc. She walks to her car, drives home through empty streets. In her apartment, she sits on the couch, staring at Commander Stahl's card, then at her phone, opens her photos, scrolls back 3 years, a picture of her unit, Helmand Province, dusty uniforms, tired faces, arms around each other. Lance Corporal David Chen stands in the middle, grinning, 22 years old, 3 days before he died. She stares at the photo for a long time, then closes it, opens her messages, types a reply to Commander Stahl. I'll do it, on one condition. I want access to Chen's file, all of it. I need to know what really happened that day. She hits send, then sets the phone down, and finally, for the first time in 3 years, allows herself to cry. 3 weeks later, the package arrives at Sarah's office via military courier. A thick manila envelope marked with official Navy seals and classification stamps, now declassified. She signs for it, closes the door, sits at her desk. Her hands rest on the envelope for a long moment before she opens it. Inside, incident reports, medical records, witness statements, and a letter. She reads the letter first. It's from Chen's commanding officer, Major Richard Vasquez, USMC, retired now. Dr. Vance, I've been waiting 3 years for someone to ask for this file. I'm glad it was you. What follows is the complete record of the incident at FOB Salerno, September 2015. I want you to know something that wasn't in the official report. Chen knew. Before you made your decision, he told me if it came down to him or civilians, you should choose the civilians. Those were his words, verbatim. He made me promise that if anything happened, you wouldn't carry it. I failed that promise. I hope this helps you keep his. Sarah's throat tightens. She reads the incident report. Multiple casualty event. Compound under mortar attack. Building collapse. Chen struck by shrapnel while providing cover for evacuating civilians. Femoral artery compromised. Massive hemorrhage. The medical assessment is clinical, detached, but the witness statements are different. A Marine corporal describes watching Sarah work. Describes her placing the tourniquet. Starting the IV. Stabilizing Chen even as the building came down around them. Describes her pulling 3 children from rubble while rounds impacted nearby. Describes her running back to Chen, finding him already gone. The timestamp between her leaving him and returning, 4 minutes. The medical examiner's addendum is attached. Time of death estimated at 1847 hours. Exsanguination from femoral artery injury. Significant blood loss prior to tourniquet placement, even with immediate surgical intervention. Probability of survival assessed at less than 5%. HM1 Vance's actions were consistent with combat triage protocols and reasonable medical judgment. 5%. Sarah reads it again. 5%. She'd carried 3 years of guilt over a decision that had a 95% chance of the same outcome regardless. She sets the papers down, closes her eyes, breathes. For the first time in 3 years, the weight doesn't crush her. It's still there. It will always be there. But it's no longer suffocating. A knock at the door. Come in. Highland enters, carrying a folder. Got a minute? Sure. He sits across from her, notices the military documents. Everything okay? Getting there. He nods, doesn't push. I wanted to show you something. He opens the folder. Inside are program statistics, charts, graphs. Your tactical emergency medicine program. 3 months in, and we're already seeing results. Sarah leans forward. What kind of results? Reduced time to critical interventions. Increased save rates in major trauma. Better interdisciplinary communication during mass casualties. He taps one of the charts. Last month, we had a multi-vehicle pileup. 8 critical patients. Your residents managed 4 of them using the damage control protocols you taught. All 4 survived. 6 months ago, we'd have lost at least 2. Sarah studies the numbers. That's good work. It's your work, your teaching. Highland sets the folder on her desk, which is why I'm recommending the program be expanded. Full departmental integration. Mandatory training for all residents and attendings. That's a big step. It's the right step. What you're teaching isn't just useful, it's essential. And other hospitals are taking notice. I've had 3 trauma directors from other level 1s ask about the curriculum. Sarah's eyebrows rise. You want to share it? I want you to scale it. Turn it into something that can be implemented nationwide. She sits back. That's ambitious. So is everything you've done since you got here. He pauses. I also heard you agreed to consult for the Navy. Word travels. It does. And for what it's worth, I think it's the right move. You've got knowledge that needs to be shared. Both here and there. I'm still figuring out how to balance it. You will. You always do. He stands to leave, then pauses. By the way, there's someone in the waiting area asking for you. Says she's family of a patient you treated. Sarah frowns. I didn't have any family meetings scheduled. She wasn't scheduled, just showed up, said it was important. Sarah follows him to the waiting area. A woman in her 30s sits by the window. Dark hair, tired eyes. She stands when she sees Sarah. Dr. Vance? Yes, can I help you? The woman's eyes well up. You saved my life. 6 months ago. The bridge collapse. I was the one everyone said was gone. Sarah's breath catches. She remembers. The woman with the tension pneumothorax. The one Highland wanted to call. I remember. How are you? I'm alive, because of you. The woman steps closer. The doctor said I was down for over 12 minutes, that I shouldn't have made it. But you wouldn't let me go. I just did my job. No, you did more than that. The woman reaches into her bag, pulls out a photo. This is my daughter. She's 4. I got to see her grow up because you refused to quit. Sarah takes the photo. A little girl with dark curls and a bright smile. She's beautiful. She asks about you, the doctor who saved Mommy. I wanted her to meet you, but I wasn't sure if that was appropriate. It's appropriate. The woman smiles through tears. Thank you for everything, for not giving up, for seeing something everyone else missed. They talk for a few more minutes. The woman leaves her contact information, makes Sarah promise to let her know if she ever needs anything. When she's gone, Sarah stands in the empty waiting room, holding the photo. Liu appears beside her. That was nice. Sarah nods. Yeah, it was. You don't get enough of those moments, the ones where you see the after. No, you don't. Liu nudges her shoulder. Come on. Your residents are waiting. You've got a simulation in 20 minutes. They walk back to the teaching space together. The residents are setting up for a mass casualty drill. Multiple mannequins, triage tags, organized chaos. Sarah steps to the front. All right, today we're running a multi-patient scenario, building collapse, limited resources. You'll be working in teams. Your goal is to stabilize and prioritize. Remember, perfect is the enemy of good. Move fast, stay calm, communicate. She starts the simulation. The residents spring into action, calling out injuries, assigning tags, working through protocols. Sarah circulates, observing, correcting when necessary, mostly just watching them apply what she's taught. One resident freezes when faced with a complex airway. Sarah steps in. "What are you thinking?" "I don't know if I should intubate or do a crick." "What does the patient need?" "Airway, fast." "Then what's faster?" The resident thinks, then reaches for the cricothyrotomy kit. "This. Good, do it." The resident performs the procedure, clean, quick. Sarah nods approval. At the end of the simulation, they debrief, discuss what went well, what could improve. Patterson raises a hand. "Dr. Vance, how do you stay calm when everything is falling apart?" Sarah considers the question. "You don't stay calm by ignoring the chaos. You stay calm by trusting your training, by knowing that you've prepared for this, that you have the skills and the knowledge to handle it. Fear doesn't disappear. You just get better at working through it." Another resident speaks up. "What if you make the wrong call?" "You will, eventually. Everyone does. The key is to make the best call you can with the information you have. Then you learn from it. You don't let it paralyze you." The session ends. The residents file out. Sarah stays behind, resetting the space. Her phone buzzes. A text from Commander Stahl. "Received your acceptance. First training session scheduled for next month. Pendleton, 2 weeks. Details to follow. Looking forward to working with you." She stares at the message, then types back. "Looking forward to it." Another text comes in. This one from Miguel Torres, the construction worker. "Ran my first 5K today. Finished it. Thank you for giving me my life back." She smiles, types, "You did the work. Proud of you." At the end of her shift, Sarah walks through the department one last time. It's quieter now. Late evening. The rush has passed. She stops at Trauma 1, the bay where she brought back the construction worker, where she refused to quit. Highland finds her there. "Heading out?" "Yeah. Long day. Good day, though." "Yeah, it was." They stand in comfortable silence for a moment. "You know," Highland says, "when you first got here, I wasn't sure about you. Thought you were too unconventional, too willing to break protocol. And now? Now, I think that's exactly what we needed. Someone who knows when the rules help and when they hurt." Sarah looks at him. "I'm still figuring that out. We all are, but you're better at it than most." He leaves. Sarah stands alone in the empty trauma bay. She thinks about Chen, about the children, about Miguel and the woman with the little girl, about all the lives saved and the ones lost, about carrying the weight and learning to set some of it down. She pulls out her phone, opens her photos, looks at the picture of her unit one more time. Chen's face smiling back at her. She whispers to the empty room, "I'm trying. I hope that's enough." Then she closes the photo, walks out of the trauma bay, through the department, past the residents studying at the desk, past Lou restocking supplies, past Jake wheeling in a new patient. She nods to them as she passes. They nod back, respect, unspoken, earned. Outside, the city is alive with lights and sound. Ambulances arriving, people moving, life continuing in all its messy, complicated, beautiful chaos. Sarah's pager goes off. Mass casualty alert, multi-vehicle accident, all available personnel. She doesn't hesitate, just turns around, walks back through the doors, back into the department. Lou sees her coming. "Thought you were leaving." "I was. Plans changed." "They always do." Sarah pulls on a gown. "Which bay?" "Trauma 2. Your lead." Sarah moves toward the bay, steady, focused, ready. The doors burst open. Paramedics rush in with the first patient, and Sarah does what she's always done, what she was trained to do, what she'll keep doing for as long as people need her. She saves lives, one patient at a time, one decision at a time, one moment at a time. The monitor beeps, the trauma bay fills, and Dr. Sarah Vance, former Navy hospital corpsman, Silver Star recipient, teacher, healer, refuses to quit. Not today, not ever. The end.